Welcome back, everybody. Welcome to lecture 11. Today we're going to be looking at bone formation and development. What did you learn between last lecture and today? Have you practiced your terminology? Do you remember what the 4 types of bone cells are and what they do? Do you remember all the structures that we went over as far as the components of a long bone and flat bones and red marrow and yellow marrow and what do they do? I hope so, because we're going to be applying a lot of that to today's lectures. So let's go ahead and get started. Okay, there we go. And let's talk about our 3 stages of bone development. We've got 3 to look at. First is bone formation, or also called osteogenesis. We have postnatal bone growth, and then we have bone remodeling and repair. Now our first stage is bone formation, or osteogenesis. Now take a look at these images over here. And these are showing you the development of a fetus. And in here we can see all this red cartilage. Okay? Down here we can see that this 10-week-old fetus is made up of mostly cartilage. And as we are born, by the time we're born, a lot of that has been replaced by bone, and we have just some residual cartilage in some areas of our skeleton. Now, pre-8 weeks, our embryonic skeleton is all hyaline cartilage and fibrous membranes. It's really important because we're going to talk about hyaline cartilage and fibrous membranes here in a couple of slides. Chondroblasts are making the cartilage framework. So if you remember, we talked about osteoblasts were building bone. Chondroblasts are building cartilage, okay? And chondrocytes are going to maintain that cartilage, just like osteocytes will maintain the bone. Now, bone is like a replacement tissue, if you will. It forms on the cartilage matrix. So you can see in this image, I've got this image of a house, and we've got this framework of wood that is kind of the skeleton of our homes, if you will. And so in order for us to put on our drywall, we have to have this framework below it so that we can form our rooms and hang our windows and hang the drywall and then paint it and hang up stuff on the walls. So bone is doing the same thing with cartilage. It's replacing cartilage, which is why when we look at this bottom right image, you can see we've got lots of cartilage at 10 weeks, but by the time we are born, we have a lot more bone that has replaced that cartilage. At birth, most of that cartilage is replaced, and again, we'll see how that's changing. But if you remember, we always have that hyaline cartilage around the ends of our bones where we have articulations. So let's look a little bit closer at this process. There's 2 types of bone formation that we're going to learn. The first is called intramembranous ossification. So ossification is basically forming bone or solidifying bone. Intra, within, membrane, membranous. Okay, so our bone is developing from the fibrous membranes, which I just mentioned on our previous slides. This is going to eventually develop into our flat bones, so our facial bones, our cranial bones, our ribs, right? The other type of bone formation, or the other type of osteogenesis, is endochondral ossification. And so this is where bone is replacing the hyaline cartilage, and that's what's forming most of our skeleton. So first let's look at intramembranous ossification. Intra, within, membranous, membrane, ossification, bone formation, right? So we're going to have bone formation within a membrane. Now this is going to form most of our flat bones in our bodies. So when we think of our cranial bones or our ribs, we're starting as membranes that eventually become bone. Now within those membranes, we have mesenchymal stem cells. And so this tissue is derived from our mesoderm during development. those mesenchymal stem cells start to cluster and they develop or differentiate into osteogenic progenitor cells or osteogenic stem cells. Those stem cells then differentiate, unipotency here, into osteoblasts. Okay? Now those osteoblasts are going to start to secrete osteoid, and you can see that being represented here with these little lysosomes being released from the cell and being deposited into the surrounding vicinity. Okay? And so we can call this an ossification center. So a little part or a center that begins to solidify and become bone. So the next phase is calcification. Now what we see here in this image is we still have that membranous background here, but what we can see is that we've got some newly deposited bone, and we have our osteoblasts around the outside perimeter of the bone, and within the bone we have our osteocytes. So as the osteoid has been deposited around our osteoblasts, eventually that osteoid starts to become calcified and gets really, really hard. Again, it's like our analogy, building yourself inside of a brick wall. So those osteoblasts now become osteocytes, and their main job is to maintain and regulate that bone matrix around them. There are the residual osteoblasts that are around the outside of that bone, and more of those progenitor cells are developing into these osteoblasts. And you can see that they're continuing to release these lysosomes with osteoid in them. Next, we start to form some trabeculae. So that extracellular matrix, it starts to get a little bit porous, and as it's being remodeled a little bit, we have vascularization by our blood vessels, and that starts to weave in and out of those little trabeculae, forming our spongy bone. You can see that we're also starting to condense some more of those mesenchymal cells, which are going to start to form our periosteum around the outside of this bone, and that's going to allow for that vascularization and innervation of the bone. Our last stage then is the development of that periosteum. So we can see that now our osteoblasts have laid down more bone, and they've formed this plate of compact bone over here. We have our plate of compact bone over here. So our periosteum is lining the outsides of our bone. We'll have some endosteum on the inside that has osteoclasts that's helping to remodel that bone a little bit and help form those trabeculae. And these osteoblasts are going to continue to put down bone to make this thicker and more sturdy. Again, this is where our red marrow is going to start to form so that we can have red blood cell formation and white blood cell formation. So a really great example of where we see intramembranous ossification is in our fontanelles. These are the soft spots, the membranes between our parietal and frontal occipital bones that allow for those bones to move during birth, so that when they're coming out of the birth canal, they have some flexibility. Sometimes you'll see a child with a cone head because of that birth, but then eventually they'll move back into their right shape. After about a year, these membranes have fully ossified. Okay, and so this is just a nice application of where this intramembranous ossification is happening. So we're taking this membrane and developing flat bones out of that. Now we're going to talk about another process, the second process, called endochondral ossification. All right, so endochondral, so within the cartilage, and we're going to form bone within that cartilage. Now, if we look at this image here, we've got week 9, so we're talking about fetal development. And within that cartilage framework, what we see happening is that we develop a bone collar. So a little bit of osteoid is deposited along these long bones, and that gives some rigidity to that cartilage so that we have this really secure framework to start adding more weight and more bone. So that first part is that we form a bone collar around our hyaline cartilage, and then we start to see the development of a primary ossification center. So kind of like what we just talked about with our intramembranous ossification center, we see the formation of osteoblasts right in here. Now, that perichondrium, remember, is on the outside of that cartilage, and that is going to start to form into the periosteum to help form that bone collar. Our stem cells are becoming our osteoblasts, and those osteoblasts are putting down that bone to support our development. What's happening then is those chondrocytes within the cartilage start to hypertrophy, and our extracellular matrix starts to calcify. Okay, and so again, bringing in some of our previous terminology, they're getting larger in size. Now, our next stage that's happening here in endochondral ossification is that we see this interior portion start to degrade. So, and this is going to be our eventual diaphysis. And so that cartilage deteriorates, starts to form some little cavities in there. And then what happens around month 3 is we see the formation of periosteal buds. So we see the invasion of blood vessels into our diaphysis. So that periosteal bud comes into the cavity. We see those osteogenic stem cells become osteoblasts. Those osteoblasts start secreting osteoid through lysosomes around themselves, and we start to form spongy bone. Just like we talked about with our intramembranous ossification, we start getting those trabeculae, and we can start adding in more blood vessels. Right around birth, we start to see that our diaphyses have been ossified, and we have a big medullary cavity. So our diaphysis is elongating, our medullary canal is formed, and then we see secondary ossification centers in our epiphyses, here and here. So essentially the same thing we saw with our primary ossification center starts happening up in the epiphyses so that we can start forming more spongy bone up here. Again, chondrocytes start to hypertrophy, and we form these periosteal buds. And then between childhood and adolescence, we start to see that the epiphyses are ossifying. And that epiphyseal plate, where we have the residual hyaline cartilage, is where we're going to go next with our bone development. That space remains cartilage until we get, around 18, 20 years old, when we stop growing, and that epiphyseal plate becomes our epiphyseal line. So we have new cartilage that's then replaced by bone as it grows, and we're going to look at that process here soon. And the last thing is that we can see the articular cartilage on the ends of our long bones at our joints, so that is reducing friction and reducing bone-on-bone rubbing. So here's the entire image of endochondral ossification. Just to start over, we form a bone collar, we have a primary ossification center, we degrade a little bit of that cartilage, we get vascularization into our diaphysis, we're forming compact bone and spongy bone and more vascularization, and at the same time we're getting a secondary ossification center in our epiphyses, and then between childhood and adolescence our bones are growing and lengthening at the epiphyseal plate until we get to about 18 to 20 years where that plate becomes the epiphyseal line, and along the whole way this bone is being remodeled, and we're going to talk about how that bone is being remodeled next. So postnatal bone growth happens until adulthood. So we have two types of postnatal bone growth: interstitial growth, growth in the length of those long bones, and then we have appositional growth, and that's increasing the thickness and the girth of those bones. So if we look at a child's hand, I think this is a pretty cool image. I think x-rays are awesome, but we can see that we have these diaphyses of our bones, we can see the epiphyses of our bones, and we can see all of these epiphyseal plates in all of these long bones. And so all of those are going to eventually fuse. So all of this that we're about to talk about is happening at every single one of these epiphyseal plates. Now let's look first at interstitial growth. You can see over here on the left, I've got a femur, and I've got two arrows here. And the reason I have these two arrows is to represent that the growth at these growth plates, interstitial growth, is happening between this epiphysis and diaphysis and between this epiphysis and diaphysis. So at both growth plates. So this image is basically representing the growth plate up here in the superior or the proximal portion of this bone, whereas if we were to flip this around, it would be representative of what's going on down here. Okay, so let's look a little bit at these zones first. So our first zone is called the reserve zone. So just to clarify here, we have our epiphysis of our spongy bone, which would be up here, this is up here, and our diaphysis, this part of the bone way down here, just to kind of give you reference. So we're zooming in on the growth plate and the different zones within those growth plates. On the right side, we're going to be looking at the changes in the chondrocytes, what's happening to those chondrocytes only, okay? Now, if we look at our reserve zone, what we've got going on is just basic chondrocytes are hanging out, they're maintaining their matrix, and we have chondroblasts that are going to be depositing a little bit of new cartilage up along this red line up in here. Our next zone is the proliferative zone, and our proliferative zone is designated or is classified by high rates of mitosis. So those chondrocytes are splitting and they begin stacking on top of each other, and so we can see that we have this organized pattern here with those chondrocytes. And so again, we're increasing the numbers of cells, so that's hyperplasia. Where below that we see maturation and hypertrophy. So here what's happening is that these cells start enlarging and they start to calcify the matrix around them. We can see that lipids, glycogen, alkaline phosphatases start to accumulate, but what's really important is to know that we start to calcify this bone, or sorry, this cartilage around these chondrocytes. In doing so, those cells basically are committing suicide. Those chondrocytes are dying, and we now are left with this calcified matrix. And then below that is our zone of ossification. So those osteogenic stem cells, they've moved into those areas where our chondrocytes were, and they start to deposit osteoid, and that bone then is a replacement tissue, like we said, takes precedence and replaces that calcified cartilage that was there, and we have a really hard, rigid bone added on to that diaphysis. This is just another way of looking at it. It's a histological view, just that might be a little bit more helpful for you to gain an understanding of what's happening with these cells. And you can just see the the descriptions of those zones along the side here. So I'm not going to go over it. I just wanted to put that in as an extra resource. So let's try to imagine or visualize what we've got going on. So here we are with our image or cartoon image with our 5 zones. So here's our reserve zone right here, and here's that ossification zone. Here's our epiphyseal plates, okay? So what's happening, if you remember, we're gonna have bone growth in this direction and in this direction downwards. And so this diaphysis is going to extend, okay? And so what I'm basically doing here is, as I skip through, what we can see is that our zone of ossification has gotten longer down here, but we have just moved up, and our bone is now a little bit longer right here. If we continue through another phase, we're adding bone at the bottom, and all of these zones are moving up. So we're adding cartilage up here, and we're adding bone below. And as that bone extends, and as these processes continue, we get bone growth. And this is happening at the same, at the bottom portion, or the distal portion of our tibia here. And so over time, this continues to grow, elongating that diaphysis until we get to about 18 to 20 years, and then our hormones stop our growth plates. So that's regulated by hormones. So growth hormone is stimulating the epiphyseal plate activity, while thyroid hormone is kind of modulating or regulating how much growth hormone is available. And then our testosterone and our estrogens are stimulating growth spurts, but they're also shutting it down when we get to about 18 to 20 years. So all of these hormones are regulating this process. And those hormones are released from endocrine glands, which travel through our circulatory system into our skeletal system. Now, appositional growth, we said that was interstitial growth. Now we're looking at appositional growth. Appositional growth is thickening our bones. So as we get older and bigger and grow, we put more weight on our bones, we put more forces on our bones. So those bones need to be thicker and be able to withstand the forces that we're putting on them. So as an infant, you can see here in this image, we've got our periosteum on the outside. We've got our medullary cavity and that endosteum on the inside. And so what's going to happen as we grow, we can see that bone is deposited on the outsides of our bone, on the perimeter of our bone, and deposited by those osteoblasts, while the inside is resorbed by those osteoclasts. And so if we just deposited bone and never cut away at any of that bone on the inside, those medullary cavities would never get any bigger. We wouldn't have as much space for marrow and blood vessels, and those bones would get really heavy and they'd be a lot harder to move and they'd be real clunky for us. By the time we're a young adult, you can see that process is continuing, and once we become an adult, we stop that appositional growth, and our bones are just kind of in a state of remodeling where we maintain those. Now, 2 types of dwarfism: achondroplastic dwarfism, so without cartilage. Basically, our long bones stop growing in childhood. So what we tend to see are individuals with a normal torso but very short limbs. And so that's the failure of those cartilage growth in those epiphyseal plates. And so if the cartilage isn't extending, well then we don't have more cartilage to replace with bone. So once that growth plate stops or is replaced by bone, there's no more growth. Pituitary dwarfism is just a lack of growth hormone or underproduction of growth hormone. And so generally you have normal proportions, but you're just all around smaller. So we've made it through bone growth and development. Let's talk about a few more things, but first, here's some good questions for you to practice. These are example test questions, just so you have an idea of what I might be asking you on our upcoming exam. All right, so how'd we do? So let's look at these real quick. Number 1, which type of bone development is responsible for increasing the girth or widening of a bone? That would be C, appositional growth. Number 2, put the stages of intramembranous ossification in order. So basically we start with an ossification center, which then we need to calcify. Then we need to form trabeculae, and then we surround that with periosteum. So that would be D. And number 3, which of the following is matched incorrectly? That would be C, appositional growth, increasing the length of bones. We just said that that was increasing the girth of bones, where interstitial growth would be increasing the length of bones, and D, interstitial growth, occurs at the epiphyseal line. Ooh, that one is also wrong because epiphyseal line is already ossified, so it's an epiphyseal plate. So the interstitial growth technically is occurring at the epiphyseal plate. So E would be the correct answer on this one. Great. So let's look at bone remodeling, depositing, and resorption. And what does that all mean? So we're going to talk about that as we move forward. All right, so we're working through our stages of bone development. All right, now bone remodeling and repair. This happens at all stages of life. Remember, bone formation, that is when we're talking about our fetal development. Postnatal growth after we're born was what we just looked at with interstitial and appositional growth. Now we're talking about from birth until death. Bone deposit and bone resorption. Now, real quick, resorption, that is not a misspelling. Resorption is basically the process of losing some kind of substance, right, from our bones. We're resorbing it back into the blood, where reabsorption is absorbing something again, so we're reabsorbing it, okay? So kind of a little fine line there, but it does matter. So when we talk about bone deposit, this is occurring where bones are injured or we need to add more strength. So you can see those osteoblasts. Those osteoblasts are depositing their osteoid onto the bone that was there prior to the deposition. So we're going to build bone by those osteoblasts. Osteoclasts then, if you remember, they have those frilled edges to increase surface area. They're releasing hydrogen ions and digestive enzymes, and that's going to make these calcium salts more soluble, and they're going to digest that organic matrix and resorb that those chemicals. So they're basically exocytosing these enzymes, and then they are transcytosing, or bringing those digested material back into their bodies through endocytosis, moving them across the cell, and then out the other side and exocytosing them into the blood. Now what we see is bone remodeling, and bone remodeling is controlled in 2 ways. One is hormonal mechanisms, and 2 is mechanical and gravitational forces. So we can see here that we've got our epiphyseal plate, and you can see that we have resorbed bone along this red line, and so we've changed the shape or remodeled the shape of our bone. So what does that look like? Well, the first way we do that is with blood calcium, or regulating blood calcium. So we have 2 hormones that are coming out of our endocrine system that you're going to need to be familiar with. So we have our parathyroid hormone that's being released from our parathyroid glands. Then we have calcitonin that's being released from our thyroid glands. The parathyroid glands are on the thyroid gland, and that's right up here in our neck. Now, if we look at hormone regulation of bone remodeling, we can also call it calcium homeostasis. So we've seen an image very similar where we've got our little balance beam, and now this blood calcium levels are out of balance. Okay, they are out of our normal range of 9 to 11 milligrams. And so what we see, if our blood calcium levels increase, right, is that we are stimulating our thyroid gland to release calcitonin. Calcitonin increases in our circulation. Calcitonin then travels to our bones And what it's going to do is it's going to stimulate bone deposition or calcium deposition in our bones. And so this is going to trigger our osteoblasts to increase work, and it's going to reduce the osteoclast activity. So let's think about that for a second here. Let me give you a big pile of bricks. And so in that pile of bricks, those are calcium molecules. Now let's say I have a big dump truck that drives up and dumps a whole bunch more bricks in this pile. Well, now we can consider that as an increase rise in our calcium levels. So calcitonin is stimulating you to take those bricks and start building a wall. So you're pulling these bricks out of that pile and trying to build and build and build and build and get them out of this pile and get them out of circulation. At the same time, it's inactivating or reducing the activity of osteoclasts, which as you're putting 4 bricks on, you've got an osteoclast that's taking 1 or 2 bricks off. So they reduce that osteoclast activity, and that's going to bring us back to our homeostasis. Now, if calcium levels drop, there's a trigger to our parathyroid glands, and you can see those 4 parathyroid glands on the posterior portion of the thyroid gland, and they are going to release parathyroid hormone. Parathyroid hormone increases in concentration, and that's going to trigger the activity of the osteoclasts and reduce the activity of the osteoblasts. So the osteoclast worker starts taking the bricks off of your wall and throwing them back into the pile or back into your blood vessels because we need more calcium into the blood, and that brings us back to our homeostatic balance. This is guaranteed you'll have a couple of test questions on this, so spend some time learning these hormones. What do they do? What are their effects? How do they regulate blood calcium homeostasis? Now, that bone remodeling also is affected mechanically and gravitationally. So there's something called Wolff's Law, and this is basically states that bone grows or remodels in response to forces or demands. So some of the observations that support this law are our handedness. So for those of you that are right-handed people, your right arm is getting used more often than your left arm, and vice versa. If you're left-handed, your left hand is being used more often. If you compare those bones to one another, if you're right-handed, the bones in your right arm will be thicker and a little bit stronger than your left hand because you use that most often. So those forces that you're putting on those muscles therefore transfer over to the bones and stimulate those bones to be thicker and stronger. Curved bones like your femur tend to be thicker where they can buckle. So in your middle of your femur, you'll see a lot more compact bone that is deposited in that weaker area. And the trabeculae form along lines of stress. So if you're looking at this image on the left, we can see that here's your body weight pushing down on the head of this femur, but that's causing a force into your bone. And so we also have tension and compressional forces here as well. So those trabeculae are going to be remodeled along those lines of stress to help reinforce that bone. And then last, large bony projections also form where we have really big muscles that are attaching to our bones. So our gluteus maximus and our quadriceps muscles, our biceps femoris muscles, right? So we should see larger bony projections so that they can resist those forces by the bones or by the muscles. Great. Let's look at a few more things and then we'll be done for today. So bone fractures and repair. Now, we can classify bone fractures into a few different ways. We can look at the orientation of the break. Is it linear, running in line with that bone, or is it transverse, so like our transverse planes? What is the completeness of the break? Is it totally complete, broke all the way through, or is it incomplete? What's the position of the bone ends after the fracture? So is it displaced or non-displaced? Did they shift out of placement? Or did it penetrate the skin? So compound fractures are when the bone penetrates the skin, and simple is not penetrating the skin. If we look at comminuted fractures, are bone fragments into 3 or more pieces. These generally happen and are more common with elderly folks because those bones become a little bit more brittle, so when they fall or twist, those bones kind of shatter. Now, just to throw this out here, you will be required to know these different breaks for a test. So what would I ask you? I would give you some kind of situation where I might say you're working in a nursing home, one of your patients falls and breaks their tibia. What type of fracture is most likely occurring at this site? And so because here I said that particularly common in the aged, then you would probably answer comminuted, okay, depending on these questions. So just to give you a heads up as you're studying this information. Compressional fractures, the bone actually gets crushed, so we see this in osteoporotic individuals where they're really porous, or if they fall. Spiral fractures, these are generally kind of ragged, and this is when we have these twisting forces applied to a bone. We see a lot of these spiral fractures in sports. An epiphyseal fracture happens along the growth plate, and so the diaphysis and the epiphysis break at that epiphyseal plate, and this generally happens where those cartilage cells are dying, but we haven't formed bone yet, so it's where we're kind of leaving that calcified shell, and it's weaker, so it's not as strong and flexible as that hyaline cartilage, and it's not as strong as the bone, so point of weakness. A depression fracture is when a broken bone is pressed inwards. So a lot of times we see this in skull fractures where we're in a car accident or get hit in the head with some kind of object or a bat or something falls on someone's head. And then a green stick fracture gets its name from like green sticks. Literally, when you try to break a green stick, it usually just kind of breaks incompletely and breaks on one side, but not all the way through, whereas a dead stick, you snap it and it breaks right in half. So the bone breaks incompletely, and we generally only see one side of that shaft breaking. This is really common in children because they have a little bit more organic matrix, and so they're more flexible, and their bones are a little bit more rubbery, if you will, and so we tend to see more green stick fractures there. So here's some practice questions for you. Go ahead and pause your video. You can work on this now or later if you'd like. I'll see you in a few minutes. All right, welcome back. Let's move on and go over our last bit of information here, healing bone. We'll talk about healing bone and then some pathologies with bone. So there's 4 stages of bone healing. So we fracture our bone and now our body wants to fix it. So a hematoma forms. Remember, blood is escaping from those capillaries. We get a nice big bruise around that area, and we're going to bring in a lot of our immune cells, our white blood cells, to clean up the area. Next, we get a fibrocartilaginous callus. So we want to our bodies want to try to hold those bones in place. And so when we put a cast around a broken bone, that helps keep those in place and helps the healing process be more efficient, because if you didn't have a cast, some of us take them off. At some point we're like, I can't do anything. We take them off and we move, and we get friction and forces on that weak point of those bones, and that's gonna slow down the healing process. So here we allow fibrocartilage to form and help hold those 2 bones together. The next stage is then we form a bony callus. So just like we saw before, we are replacing cartilage. So remember, fibrocartilaginous cartilage, right? Fibrocartilage. and so lots of collagen fibers, really strong. Now we're going to replace that cartilage with bone, and we form this bony callus. And you'll see in this image that it's not always the cleanest formation and healing process here. So we need to remodel that bone, and that's our last stage. So there'll obviously be some tissue damage in there, but we can see that most of that bone then gets reformed back to its normal shape so that it can withstand those forces that it's used to you putting on it. So homeostatic imbalances of bone. So we're going to talk about rickets, osteomalacia, osteoporosis, and Paget's disease, and you'll need to know these for our tests. So our first one is rickets. As you can see here, our normal anatomy versus an individual that would have rickets. We can also call it osteomalacia, and this is where calcium salts are not deposited appropriately. In adults, we call it osteomalacia. In children, we call it rickets. Those calcium salts are not deposited, so those bones are a little bit softer, right? It causes a bow-legged formation and other bone deformities along the way because they don't have that really strong calcification of that bone material. Generally, this happens because of vitamin D deficiency. So when you think back to our integumentary system not making enough vitamin D, or just dietary vitamin D as well, or an insufficient calcium in our diet. So this is why you always see orange juice that's fortified with calcium and vitamin D, or you hear a lot about drinking milk and making sure you have enough dairy in your diet, is so that we can have really strong bones. Now, osteoporosis is the loss of bone mass, and so bone resorption is faster or outpacing our bone deposition. And so we can see that our normal bone up here in the top is nice and strong, and down here we see the loss of some of that bone material because of those osteoclasts. So this can be a result of age, a result of our hormonal imbalances that are kind of regulating our osteoblast and osteoclast activity. And last, we have Paget's disease. So we have excessive bone breakdown and sort of disorganized bone deposition, which causes these abnormal curvatures to the bones. We tend to see higher ratio of spongy bone to compact bone, and a loss of that mineralization of the bone as well. Then we have osteoarthritis and rheumatoid arthritis. So if we look here, we've got our healthy joint surrounded by our synovial cavity, our connective tissue membranes that is producing the synovial fluid that lubricates the hyaline cartilage on the ends of our long bones, so that we have this nice reduced friction environment. Well, osteoarthritis is, as we get older, that cartilage breaks down and we start to get some bone on bone rubbing, and that can be pretty painful and lead to ossification of those bones. In rheumatoid arthritis, though, it's an autoimmune disease that actually attacks the articular cartilage and eventually results in ossification, swelling, and soreness at those joints. A sprain, if we look at sprains are damage to the ligaments, whereas strains are damage to the muscles around those joints. And then a cartilaginous tear, here's just an image of a torn meniscus. So if you've ever had one and haven't seen what it looks like in your knee, that's generally what it looks like. And sometimes they can go in and do surgery and remove a piece and heal it, and other times they won't do anything about it. So we've made it through lecture 11. That brings us to the end of our bone lectures. You have another test right around the corner, so I wish you the best of luck on that test. Don't forget, you are only getting one question at a time. You will be timed, and you'll have have a few days to take that, so make sure you find a good spot with internet and stop in at the library, check out a laptop if you need one. Otherwise, best of luck, and I will see you at our next lecture when we start with Unit 3, learning about the nervous system and how we regulate and send electrical signals throughout our body. Have a great afternoon.